Thank you for listening to the Gilman Woolsey podcast. This is episode number 10. I hope you enjoy the show. So today we have Jordan Madrid. Jordan is an EMT working over in Albuquerque, New Mexico, that was put in touch with me, and we're going to be discussing the state of preparedness that we are right now in various communities for the virus, also planning going forward and what we can expect. Welcome, Jordan. How are you doing?
I'm good. Thank you for having me on. I'm pretty excited to talk with you today about some of this stuff.
Yeah, thanks for coming on. First thing I wanted to talk to you about was what in your community you're seeing as far as the preparedness, and how much are you seeing shortages or other concern that your community is going to have sufficient preparation and supplies to deal with what we're expecting?
I think we're seeing a pretty critical level of shortages. I don't think anyone really has prepared for anything like this as much. So I do work in the field, and I do also work in one of the three core facilities here in my state. And it's kind of weird how they both act as two different beasts, if you will. The hospital systems kind of don't really plan for the worst, at least in my state. We do have, protocols and stuff for the outliers and for certain disastrous situations. But, N95 respirators, I don't think was something that ever seemed that we'd ever be shortage on. And, the hospital definitely didn't have that stockpile. We do have a larger stockpile with the people that are out in the field for the 911 system. So the hospital, we have already reached the critical levels. So now it's, we're only getting them as we have a confirmed COVID-19 patient or another airborne type illness, only when we're doing aerosolizing interventions. So that would be, intubating them, using manual pressure like the CPAP machine or anything of that nature to where it could aerosolize these agents. But it's kind of a delay in getting to the providers in the ER, especially as those interventions, those are rapid. Like if you're going to do that on the spot, there's not many times where you prepare for it. It's kind of that patient's really decompensating, and then everyone just rushes, and our instinct is to go in there and take care of that patient, and then the PPE will kind of come secondary. And they are also trying to keep the older providers that are at higher risk with them as well in the hospital. And now we're just trying to see how long we can stretch the current supply that we have. Mm-hmm. So we have reached critical levels. We are doing about a 2 to 3 hour audit in the ER of our logistics team. They're going in and counting and inventorying how much we have. And we do have other forms of PPE because there's a vast majority of different sizes and shapes of the N95. And we're getting, different kinds, and we're getting kind of test fitted on the spot as we need them. Mm-hmm. So that way we can do that. We have also been advised to reuse them. We can keep them on for up to 8 hours straight. If they do become visibly soiled or dirty, then you kind of got to, disregard with them. So they are urging us to reuse them if possible, put them in a paper bag and hang it up somewhere, put it somewhere, and reuse it for the next patient if possible. I don't think that's something that's really doable at the current moment.
That's really a couple interesting points there that you bring up. First of all, we've seen on our end rationing. It used to be that you could walk into any closet and there would just be boxes of different masks, both surgical and N95. And now in a lot of the hospital settings, we're starting to see they're kind of locked up and almost kind of rationed. They're handed out, they're controlled in ways that they never were before. But I think what the hospital is doing there, trying to prioritize for the older providers, I don't think that's necessarily fair, but from a epidemiologic standpoint, from the standpoint of protecting the people most at risk, the policy from that standpoint makes sense, even though everyone is somewhat at risk. You mentioned that there were, well, actually another point that I hadn't thought of that's interesting is the variable sizes of masks. When people are talking about stock and supplies, it's a little more complicated than just, the number of masks with an N95 type mask. Different people wear different sizes, and the goal is to cut all airflow off from around the edges. And if you don't, it's not 100% effective. So it's a matter of getting the right type and the right sizes of masks to people and even distribution, which complicates the matter. You mentioned something about other types of PPE that they were using. What did you mean by that?
Yeah, so there are some other types of PPE. We do have the full hoods. I'm sure you guys have seen, like with like the Ebola crisis, people with the full hazmat suits. Those hoods could also be worn individually to create a seal for you as well. The downside to that is we have 15 for the entire hospital. So as you can see, for just that standpoint, the hospital's not really ever banking on any of these, disasters to truly unfold or see the supply chain kind of get cut, which is really kind of the Achilles heel of this for the N95 respirators is the supply chain, the orders that they're getting, they can't meet the demand as of right now. And so we look to other PPE, which theoretically we should have more of, but again, that's 15 of those hoods and they are reusable, but then, you can't really share that with other providers. Also in the field, we are seeing different forms of PPE. So the fire department, when they go into fires, they have what's called a SCBA. It's a short circuit breathing apparatus. And they have started using those more and more on respiratory calls. Mm-hmm. So our new triage system is when someone will call 911, it'll go to their fire alarm room. And the 911 operators are now starting to triage. Has anyone been exposed? Any recent travel? Kind of the run through of questions. And it's been deemed now, if the fire department gets there first or if the ambulance service gets there first, the first responding unit is going to go ahead and get their PPE on. So for us, it's the N95s, the iPro, the gloves, and we'll go in. If it's the fire department, we have seen an increased use of their SCBAs. So that's a full face mask that's hooked up on, a closed circuit of oxygen that they can breathe on for 20 to 30 minutes of air, depending on how much, if their respiratory rate's higher, it's going to run through the air faster. If it's lower, it's going to elongate that air in the tank. But we've seen an increased use in that because that takes and filters out, and it doesn't allow anything. It's a closed breathing on oxygen, and that's something we've never seen before in the field unless they're working an active structure fire where there's substantial amounts of smoke. And I think that was something that's, kind of ingenious to use that gear because they can refill those tanks very readily with just the oxygen. They can fill their tanks, bleach down their helmets and their face masks, and they can reuse those. And I think that's something that's very good, especially to have for all the fire departments, because everyone has them, in the fire department. Every personnel is issued their own SCBA for their PPE in a structure fire, but it's great that it correlates over to this airborne or droplet precautions that we're on now when we arrive on scene, and then we're communicating via our radios as to when we can make patient contact after they screen them if they have any symptoms, and then they can inform us if we just need just a regular dust mask or like surgical mask, and if it is a true potential COVID person of interest, then we can know to have the N95 on when we transport, or if they're going to go by their own vehicle, which has actually helped elongate or preserve our N95 stockpile, if you will, in the field, which I think is something that we started early on and is something that's very great for the 911 system, especially with the 2-tier EMS systems like that. And the fire departments have that gear on hand.
So before, say, a month ago, was the fire department responding to these type of calls, or have they had the fire department now responding because they have protective equipment and they can be kind of like the first point of contact? How has that changed, or is it the same as it used to be?
So yeah, that's pretty much business as usual here. We run a 2-tier system. So it's going to be the ambulance and the fire department company. We're both going to get dispatched. We have the same dispatch tone. The difference is they're staying in-house at their station for 48-hour shifts, and we do anywhere from 13 to 24-hour shifts. And we respond with the city fire department, and we respond with the county fire department. And then we also have units on our local military base to respond to calls to run with the Air Force Fire Department. So we currently run the 2-tier system, and the ambulance company transports them to the hospital. And so it's business as usual there. We're not seeing an increase of that. We still have a very significant call volume. And I do think we've seen a substantial amount of triaging in the field saying, hey, the ERs they're getting pretty busy. I don't think this is something that's necessarily like an emergency room matter, because it could, potentially increase your risk of getting ill. That's something that we have seen. We've been doing a lot more of, I guess you would say, coaching in the field before than normal. Before we would arrive on scene, we would triage, and then we would just ask the question, do you want to go to the hospital today by ambulance? And if they said yes, great, we'll take you, we're happy, we're here. No, okay, then we'll give them the run through process for the refusal protocols that we have. Now we're seeing a more of, okay, you've had a headache for 5 days, and today it's a little bit worse, but you haven't taken your Tylenol today. This isn't something, just because you go by ambulance does not mean that you get a room immediately. It's the same triage process as if you were just to walk in off the street and go check in with the registrar clerk. Mm-hmm. And I think that's a big misconception. So we did see an increased 911 call volume off of that, and we have been informing them that that is not the case. It's going to be based off of what patient needs to be treated first. It's the whole purpose of triage. And now we're able to set that up, a little bit better with some video visits, to where they can speak with the provider over the phone with a mobile iPad. They can go ahead and have their conversation, and they can give them a rundown. They can do prescriptions on scene from the provider. And I think that's something that's kind of actively evolving as we go. We're kind of advising some people to potentially stay home for their safety, which is a true thing, because if someone else that comes in before them that's more sick, they're going to get the room. And, I think that's the misconception. And then if they're stuck sitting in the ER, and there's a few people out there that are experiencing the signs and symptoms of the coronavirus, they're potentially putting themselves at risk for something that, may or may not be a medical emergency right now in this moment. And so we've seen an increased level of coaching on scene for sure. And it's the 2-tier system has been running as usual, the fire department and the ambulance service running together on all calls.
Yeah, I'm curious as far as at your particular facilities. I know at a lot of the places that both Jackie and I work at, historically we've had a lot of what we call code oranges, which are either ICU beds or just hospital capacity as a total is running low. What are you seeing as far as historically the capacity of the local hospitals there? Are you seeing that the capacity has decreased in the last couple of weeks? What is kind of the general overall feel for how much additional capacity you guys can handle there?
I'd say we're already operating that max capacity. Last week, so yours is code orange, ours is code black. So we get an email out the second that hits. It's a chain email to all employees. Hey, this is where we're at. And so we were at code black last week with the initial coronavirus announcement of there was a couple cases, and then we hit code black within an hour or two. And then on top of that, we were holding 25 patients in the emergency room, and we couldn't move them anywhere. There was nowhere to really put them. They needed to be admitted. They needed to go get seen by, some other providers and to hold the care. But the caveat to that is we have 50 rooms in the ER that I work at, and we were holding 25. So that instantly cut the ER's capability by 50%. And so we did go out to the waiting room, and we were like, hey, we only have 25 beds available right now, and we're moving at 50% capacity because we're holding, 25 other patients. And we did see a huge increase. After a lot more of the coaching techniques that we have been given and allowed to use more so out in the field, we have seen a slight decrease. And I think some people also are starting to catch on, like, I'm not going to go to the ER right now for this if it's not an emergency right now. And it's kind of like a roller coaster. Some days we're getting just absolutely hammered, wrecked into the ground for the whole shift. And, I think last week I did in one shift approximately 55 to 60 IVs on different patients every time, and we were turning and burning. We did the flu swabs, the RSVs, the rapid strep, and then the COVID testing, which is then now putting an increased workload on the labs as well. And we're seeing the dates from 24 to 48 hours last week to now we're about 4 to 5 days for you to get your results back. Wow. From testing. But some days the ER, we hit code black really fast. The hospital's at full capacity, and then the ER starts holding patients, which then doesn't allow us to get people in and out and keep the patient flow moving, which then really does cripple the workforce at that point for us, because it's like we can't move these patients, but we still got to take care of them, and we still are getting ambulances. We're still having people walk in and urgent care referrals, and we only have 25 beds. So then it's like we start opening up hall beds, we start opening up and doing treatments and, certain things that we're able to do in the lobby, such as, give meds, start IVs, draw blood. And we're just going to start doing that in the waiting room or the triage area, send them back out to the lobby and, wait. I think the longest wait last week was 11 hours to get back from the waiting room to a room.
Wow.
Is what the longest I saw.
Yeah, and right now, I mean, you guys have relatively low numbers of actually confirmed infections at this point in time. And this is, I think, for people that don't work in the medical system, something that they don't entirely see or understand. A lot of our hospitals around the country are running at near max capacity already. And so to have a tremendous influx of additional people, which is happening in New York, California, Washington State, it doesn't take a whole lot to actually tip over the system. I mean, a surge of, say, 25% capacity in a lot of places, even less, has that ability to do that. One thing I wanted to ask you about, I know some of the hospitals that we've been involved in, we're seeing that they're building secondary structures, say outside of the ER or some places even on site, to basically handle pre-screening for patients coming in so that they can keep people suspected of being coronavirus positive out of the main area of the ER, and also some triage areas in case they have overflow. Are you seeing that at your hospitals there at all?
No, not here as of yet. So the 3 core facilities, we all have those triage secondary tents that we have. We haven't had to put those up yet. That's definitely on the table of discussion right now. But something that was very helpful that we implemented really fast was the drive-up testing centers. So we did put those out there. There was 3 testing centers that we have set up in the city, and they're all mobile drive-up, and that has helped substantially with people that want to go get tested. You don't have to leave your car. We'll go in, we'll swab you, and then you can drive off. And that also helps conserve some of the N95 respirators and PPE. But as of right now, we've been able to currently handle the load. It hasn't totally tipped over. We haven't seen a substantial increase. But like you were saying, is absolutely correct. We operate these hospitals at pretty close to capacity on a regular basis with other, traumas, other illnesses, and flu season alone is already putting us in those code black, situations, because it's just, it's cold and flu season. And when you add something that's more infectious, and even if you want to use the argument that it's just like the flu, we can't handle a double flu season. We can't double the flu capacity because we're already operating at it. So like you were saying, I mean, even 25% is really going to put a stress on the systems, but the hospital systems are already stressed. We already work at close to capacity. And the second you add in this, the second virus here that is shown to be pretty infectious and transmit very easily from person to person, that's just the recipe for us hitting, peak performance, and then really straining the workers, straining the logistics, and, backlogging kind of everything. I think that's some misconception that people had before. You could go to the ER, get in and out and get seen. But I mean, even for broken legs, you're still waiting there for a few hours. And now that's just going to increase the wait time for situations. If you do get a broken leg, you're going to be waiting. Like I said, last week, there was an 11-hour wait. And, the second we do start tipping over that scale with this, the second virus, we just can't handle it. And I do think we're going to see those tents start getting built up as needed. I do think the second we start building those secondary tents outside for triage, the panic might start building up. People might be becoming more and more scared, like, oh, okay, like, why are they doing that? That's not normal, right? Anything out of normal starts to make people scared. The unknown is what scares people. And I think we're doing everything in our power to try and stay away from that if we can operate at this full capacity before implementing those secondary triages and, maybe even a decon area for infectious patients. I think then the public would be kind of scared and worried some about that. So I think that's also a big factor as to why we're trying to stay away from doing that, if at all possible. And that is also why I think we were very expedient in opening up the drive-through test sites.
Right. Something else that I just saw today that actually I think is going to make a substantial difference is there was a company in California that just released a rapid test that got FDA approval that's going to allow for a 45-minute turnaround. It's kind of like a rapid flu test. So I'm really hoping that when that comes online that you're going to see that the workload you're seeing at the ERs right now decrease. Because obviously anyone that works in or around an ER, everything is about disposition. Because the sooner you can get someone in, the sooner you can get some sort of diagnosis and know what to do, you can send people home or you can admit them up into the hospital. And freeing up those ER beds is really going to be critical for having a reasonable throughput and not having people waiting in the halls for 11 hours. But at a lot of the facilities right now, I mean, it's not uncommon to see people being put into, recovery bays or hallways just because you're waiting for a bed up inside the hospital itself. So unfortunately, that rapid test isn't going to solve that issue. The other thing I wanted to ask you about was we had talked a little bit, and you had said that kind of the pulse on the ground that you're feeling when you're going out to assess people, that you're seeing kind of like a primal instinct coming out of people. And this is before the real bulk of what's likely to happen has happened. Can you describe that a little bit to us, what you meant by that?
Yeah, absolutely. So I have seen something along the lines of, more anxiety across the board when we go on scene with people. With the crowded supermarkets, Costco, Sam's Clubs, Walmart, everyone's already kind of on edge. They're a little anxious before they even get in there. And I think everyone's kind of scared to a certain extent. And that's when, when we get to a certain spectrum of, you have full-fledged panic, and then you have the people that are, this is the flu, it's going to blow over. And I think we need to try and find that middle ground of, hey, this is a problem. We need to figure out a way to deal with it, but it's not something that we need to panic about. And a lot of people have some conception of this virus is going to hit me or someone in my close circle and we could die. And it's like, so the second people are dying of this, they feel that their life is in danger. And immediately their life becomes more important than anybody else's around them, which is something that it's just, like I said before, it's a primal instinct. Like when rescue divers go in, for example, when rescue divers are going to save someone that's drowning, they have a high risk of being, getting drowned by the person that was drowning. The person they're trying to help will actively push them underwater to try and get that air. And it's kind of the same concept when you start coming into these scenes, and that mindset, it's that primal, I need to live kind of mindset. And some people have fully endorsed that and embraced it. And that's, when you start making the certain mistakes and their panic, their anxiety's through the roof, their stress, and they don't really know how to deal or process that. So we have seen an increase in some violence in, these big box stores where they're already anxious going in. They're stressed out. They're worried they're going to get the virus and die. So therefore, when someone comes into their close proximity and they're ill, they're going to instantly try and, then the fight or flight comes in. You're going to, try and get that person away from you, or you're going to alleviate yourself from the situation. And then we start boiling down to supplies that are dwindling, like meat, toilet paper, they feel that they need it more than the person next to them. And I really think that this is going to bring out the best of people and the worst. I don't think we're going to have that middle ground of the societal, courtesies as much. And, I think it's going to fall back onto that mindset of the second you tell people that they have the potential to die, someone elderly in their close circle has the potential to die. It's instantly their circle means it's more valuable than your circle. It's like, that's just how it's going to boil down. And we're starting to see more and more of that mindset kind of shift into certain things, and people then feel justified with their actions. If an intruder were to break into your home today, had you at gunpoint, and you were to have a gun, you would feel fully justified in doing so because your life is in immediate danger. Yes. And now we have a potential, something that could potentially put your life in danger. People are embracing that mindset of my life is more important. And I think we're not there yet, and we don't need to be there. And people just need to do their own research and really weigh out their options and, make the smart decisions. And when I went through my training and when I go on hot calls or, I'm in a very high stress situation, if I can't manage that, I make mistakes, and I can't have that. There's no room for mistakes in my field. And they hammered us into that by putting us in high stress scenarios all the time in school and training at work. Like, we're always put in high stress. They're always reevaluating, but the public isn't necessarily always put into those situations. So, a lot of people don't know how to manage it. And when you do that, you then become defensive. You can then become violent to a certain extent. And, you feel justified in doing so because of that primal instinct of it, kill or be killed to some extent.
Yeah.
And it's like, I have seen a substantial shift of, we had a lot of assaults. We did have a shooting and stuff like that. And this is over some supplies. And that's the mindset shift that I think that I've seen. And then I think it boils down to, the philosophy of, you got to be prepared for when you're going in to help people, that their life, if they feel that they're dying, that they're going to instantly do whatever it takes for them to survive, for their family members to survive. But we're not in that immediate of a threat. And I think that's causing even more anxiety throughout the public because of other people's reaction to it. So if we could try and hit home in that middle ground to where we're not blatantly disregarding the fact that the infection's here, the virus is here, and it can move, pretty rapidly, which we've seen. Don't be so careless to say it's just the flu. My life isn't gonna, I'm gonna go do what I want to do, live my daily life, and go hang out, go, to social events. But we don't need to be at the panic point to where you think your life is in immediate danger by going to Costco. That's not where we need to be either. And I think we're starting to see an uptake into some of that. And then I think the anxiety of some of these state shutdowns as well is just going to continue to let people get into their own heads, stay in that high stress mindset. And, people really just got to be able to manage their anxiety and stress before, and just know what they're going to do when they go out into public, such as the grocery store. Just know, hey, like, we're not in the common days. It's not like life as we once knew it, a month ago. It's not the same. People are going to be acting different. So you just got to be aware of how you're going to act, and, your mindset going into these stores. And, you don't need to be quick to draw a gun. You don't need to be quick to fight. You don't need to do any of those things. Just go in, get your supplies, and get out. It's not an immediate life threat right now. You don't need to bulk buy 12 months worth of supplies. Right. Just go in, go back out, and come back home. I think that's where it needs to be.
And even in the acute care setting inside the hospitals, and I'm sure you've seen this, certainly I've seen this, anxious patients are more difficult to deal with. It's harder to give good care to an anxious patient because even though I don't think that they mean to, a lot of times they resist it because they're very frightened. And the more calm people can stay, and I know that it's easy to say and hard to do when you're in those type of situations because feelings are hard to control, especially very primal feelings, but your outcome is likely to be better the more you can cooperate and the more you can follow directions from people. And on top of that, it creates less strain in the system because, if it takes twice as long to deal with someone that is super anxious, you could see about, twice as many patients. And so, you can deliver more care to more people. But anyways, well, I think we'll probably wrap it up here. I really wanted to thank you for your time today. And probably in maybe a couple, 3 weeks, I'd be curious to do a follow-up maybe with you and see how things have evolved and changed, because certainly right now things are evolving very, very quickly in communities all over the United States. But just wanted to thank you for your time, and I guess we'll talk later.
Yeah, absolutely. I appreciate you inviting me on to talk. And I'd definitely be up for giving you an update as to how we are going. And like you said, everything is rapidly changing. So I'll definitely keep you in the loop as to how it is here in Albuquerque and keep you up to date. Thank you.
All right. Sounds good. Stay safe. Thank you for listening to the Gilman-Woolsey podcast. We hope you enjoyed our show. As always, if you have information that you would like to share with us, or if you would like to come on our show, please contact us at COVID at gilmanwoolsey.com. We're always looking for new perspectives and to get an idea of what's going on out there. Thank you. Have a good night and be safe.